So I think we are all having a mixed bag rather than sticking to the topic which was given to us. This side. So good evening, everyone. Can I have the sound? I don't know if the voiceover is there. Okay. So this is a patient with a very extensive macular TRD, and I'm just trying to show that when you are doing a diabetic vitrectomy, it's probably a combination of everything, where I am starting to do a bimanual surgery, and in between you can shift to the cutter alone, but it has to be a very meticulous dissection, controlling the bleeders as promptly as possible, and it is a combination of everything applied together. So of course the speed of the video is a little manipulated, it's not so fast. So I think something we really need to discuss at the end would be that sometimes you have a very extensive subretinal fluid secondary to a chronic TRD, though in this case the fluid was minimal. But it's always a dilemma that after you've completed the dissection, whether you really want to resort to doing a drainage retinotomy and take out the viscous fluid secondary to a chronic TRD, or just leave it alone. This is another patient with a combined retinal detachment with a full thickness macular hole. And again here it is being managed by a bimanual surgery. So this is an extensive membrane which is being dissected out, and you can appreciate a full thickness macular hole also. And probably the macular hole had developed secondary to the chronic traction over the macula. So it is actually a combination of both reg and a tractional RD. So you have this extensive subretinal gliotic band, which was removed by making a relaxing retinotomy, and subsequent to that the dye was injected and an ILM peel was done to take care of the macular hole. And subsequently followed by an oil tamponade. So the patient apparently did well, had a closed macular hole with a good amount of visual recovery. I'm also showing one case of drainage of the suprachoroidal hemorrhage. So anterior chamber fluid infusion is fixed, and then a scleral cut down is done, and the suprachoroidal bleed is drained out using a cyclodialysis spatula. A 6 mm infusion cannula is fixed. We have to take care of putting in these trocar. The entry has to be more straight so that you can get a partial drainage of the suprachoroidal blood through the cannulas themselves. This patient apparently had some element of retinoretinal adhesions, which are being gradually released. And The posterior pole was stabilized by injecting some amount of PFCL. A relaxing retinotomy is done in the periphery to remove the subretinal blood clot. And finally, the retina is attached under the PFCL, followed by laser and followed by PFCL silicone oil exchange. So this is a high myopic patient, one-eyed gentleman, and he apparently underwent vitrectomy surgery for a total retinal detachment, and he had a very large posterior staphyloma with a full thickness macular hole, and he had already undergone a vitrectomy, membrane peeling with ILM peeling for the macular hole 2 months back. He had a well-attached retina, but the problem was that there was a persistence of the macular hole with a pocket of SRF in the area of the posterior staphyloma, and he kept complaining of a large central scotoma. So as a last resort, he was planned for amniotic membrane graft to mechanically close the macular hole. So here, under an oil infusion itself, an active suction was used to drain out the subretinal fluid from the macular area. And then an amniotic membrane graft was taken in the end gripping forceps. We have to remove the cannula because then the graft is not going to go in. And then under oil itself, you can place this amniotic membrane graft inside the macular hole. And whatever loss of silicone oil is there, of course, you can replace it by injecting more oil through the infusion. The only other option I felt for this type of a situation was a macular buckle, but of course, we are not really trained for that method of surgery. And post-operatively at 1 month, the patient did have a vision of 4/60 with a well-attached retina. The amniotic membrane graft was seen plugging the macular hole. And the patient did undergo a silicone oil removal after 6 months, and he continued to have a well-attached retina with a well-attached macula, and you could appreciate the amniotic membrane graft in place. So these are my cases. Any comments or suggestions? So I used an active suction, and of course I would agree that there would be a fluid, but I'm not placing the graft over it. I'm actually plugging it into the macula. Yeah. So that's why it stayed on.
Hi, David here from Australia. Beautiful videos and surgery. Do you guys usually do pre-op anti-VEGF before these
Diabetic
lamps?
bits,
Yeah.
yes.
There's something that we've been trying recently, which is doing a double anti-VEGF, like an anti-VEGF one week pre-op, and then another dose like a couple days pre-op. And we find that the membranes get much stiffer and less bleeding, very, very severe cases like that. Have you tried that before? No.
We are not giving 2 anti-VEGFs, we're just giving 1 anti-VEGF, and that is about 3 to 5 days before the surgery.
Yeah, same. We used to do that, and now we switched to that.
So how many days before?
So we tend to do about a week before the first one, and then the second one 2 to 3 days before.
Okay.
It's kind of a extreme loading. And the other question I had for is in a bit unrelated with your videos, but if you have a myopic macular hole detachment, is your primary tamponade longer acting gas or silicone oil? Because I've seen that some of the myopic patients here, you tend to use silicone oil, or?
No, I don't think so that we are really, all the time using silicone oil. We are quite open to the idea of using a gas as well.
Yeah, awesome.
I was just wondering, what is the purpose of using the 2 anti-VEGFs that you mentioned?
Oh, it was reported by a different group, and we've been starting doing it now more often, and we feel that we get that effect of the pre-op anti-VEGF, but even better, like the membranes get really stiffer, easier to delam, and much less angry and fibrotic.
And what about the crunch phenomena? Have you ever had that?
I think on balance, that was our fear as well, but on balance, it felt that that risk is pretty low. It almost never happens, actually. With these timings, like a week before and then a couple days before, in very tricky dilemmas like that, it's usually fine. Yeah.
Do you think the rationale is a higher VEGF load and the newer anti-VEGFs would be better used rather than 2 doses?
Yeah, perhaps that's a good point. Then until we've got better data, I think the timing of the anti-VEGF injection will always be a bit of a dilemma for us, like between that 2-3 day or a week. We feel we don't have a lot of experience with that. That's why I asked. But now, since we switched to the double anti-VEGF, doing 1 week before, and then I used to do just 2-3 days, one injection. Now we do one week before, then another one 2-3 days before. It makes the surgery much easier. Yeah.
MPS, I was wanting to ask you, are you still using that plasmin combination pre-diabetic vitrectomy, sir? He's busy with the mobile.
Earlier we used to make autologous plasmin, but now there's a modification. So you give autologous blood plus TPA. So
Autologous
blood.
blood,
So
okay.
whole blood plus TPA injected into the vitreous cavity about the 1 day before or along with anti-VEGF 2 days before. So earlier we used to draw the blood, take it to the lab, and then centrifuge
Yes.
it. You add streptokinase or urokinase, make the plasmin and inject. But subsequently, like it kind of the plasmin happens in the eye if you inject autologous blood plus TPA into the eye. So that's what we have been doing. So extremely complicated appearing combined retinal attachments with no highlight separation, with very vascular proliferation. We give all three, autologous blood plus TPA plus anti-VEGF, and then go ahead with the surgery. So as far as the anti-VEGF is concerned, like there are two things. One is like you don't want it to bleed too much, but at the same time, if we operate within 2 to 3 days, what happens? The membranes actually peel off easier because you can do like what you call a fold-back delamination much easier with the cutter. But if you leave it for longer, then it becomes more fibrous. Then you need to use a scissors and forceps.
Right.
So a younger membrane actually peels off easier, but tends to bleed. But a more older membrane or fibrous membrane, it doesn't bleed, but then the risk of breaks is there. But then you have to do much more bimanual surgery.
And there's been a lot of people, I've been seeing videos, sir, that if there is an intra bleed, which tends to stick on the surface of the retina, they were recommending that do a fluid air exchange and inject TPA and wait for 10 minutes. And then probably that is going to be liquefying the blood and you can get the blood out, the intra bleed, which has, got stuck to the surface of the retina. Anything you do?
On the other hand, it can result in more bleed also, no?
Yeah.
Because the bleeders can open up, the clots can get lysed.
Exactly.
So I have not used TPA intraoperatively, but I have used patients where you find, like I had a patient where it was operated elsewhere. We went inside and found the retina was totally detached with multiple posterior breaks and a completely plastered clot.
Okay.
In that situation, any further surgery would have resulted in a completely blind surgery. So just injected a TPA, put in PFCL, closed it up. And about a week later, then the clot lysed. It was easier for us to go back and do it. But I don't see the logic of injecting intraoperatively and then waiting for 10 minutes. Then the bleeders which you wanted stopped
They've
also
reopened.
can open up. So I am not too sure of the intraoperative use of TPA as a tool. They have used it. I think now the disc bleed, Mudit has been using fibrin blue, I think,
Yes.
on the disc.
Yes. And also for suprachoroidal bleed, I think people are recommending injecting
That we have
TPA.
used. That we have
Does
used.
it work?
Yeah, it works.
So
In
do
the
you give
sense
it in multiple quadrants?
you can inject in multiple quadrants, or you can inject in one quadrant also. So you can inject, and then it allows you to take the patient up for surgery much earlier. Earlier, you used to wait for about a week to 10 days, serial ultrasound to see if the blood is liquefied and then do it. But now we have injected suprachoroidal TPA, and then probably in 3 to 5 days we can take it up for drainage.
Thank you, sir.
Ma'am, good evening, ma'am. Always a learning experience seeing your videos, ma'am. Ma'am, I had two questions. Like in the case scenario 2, where ma'am TRD with an MH, ma'am, the tamponade was oil. Could we have done gas in that?
Absolutely, you can do gas. I'm sure there must have been some other indication which I can't recollect. But I would have opted, I mean, my first choice would have been a gas in such a situation. I don't think I'm compelled to use oil.
And ma'am, an extension to that question only, the case one, where ma'am, you were also mentioning where there was a lot of extensive TRD, and there was a fluid at the posterior pole. So post dissection, now these cases, ma'am, should we again put a tamponade or just leave them under
Just leave
fluid?
them alone. If you don't have a break, I see no reason why we need a tamponade. But
With that SRF remaining behind,
it's because of the chronic TRD. Like in my case, there was hardly any fluid. That you can just see a very small quantity. So that's going to just resolve. The maximum that you can do sometimes is a fluid air exchange at the end. But they don't need a tamponade. But yes, I actually wanted a comment from everybody that if you're having this chronic TRDs with a lot of fluid at the macula, if you just leave them alone, sometimes they take months to settle down. I mean, would you resort to doing a drainage retinotomy, putting in a tamponade, or you would just leave it alone and not convert a TRD into a reg RD?
So sometimes what we do, especially it's involving the macula, we don't make a drainage retinotomy, but just put in a short-acting gas. So mostly it comes off from the macular area and then it absorbs faster. At least so we have seen.
Yeah, we
Actually,
tend to.
I have tried draining also, but sometimes you're not able to drain also. Fluid still remains. So it appears like because of the chronic TRD, the retina has become a little bit like contracted. Even if you try to drain, the fluid doesn't come off, and that detachment remains in the post-operative period for few months.
Right. So you would just leave it alone.
I think it is better because depending on the experience, if you're not able to drain also, then better to leave it like this. And it takes months also, maybe up to 1 year also. I've seen
it
few
takes
patients
very long time.
for the fluid to go off, but generally it goes off.
We also leave it alone, and I feel that sometimes surprisingly a significant macular subretinal fluid doesn't impact that much in the vision in these type of cases compared with an acute detachment.
Right.
So we tend to leave it alone.
So I think we need to close, and thank you, Dr. Manisha, and
Thank